dose of edrophonium, it makes your symptoms worse. Your heart rate falls, your blood pressure falls, your lungs start filling up with fluids. I'm poisoning you with the edrophonium. Or if you were in a myasthenic crisis, I give you the edrophonium, your muscle tone comes back. You can actually now swallow. You can take that drink of water if you're strong. Okay? The ability to swallow is one of the easiest things for y'all to assess. And it's one of those on command, okay? Because what's the sign that you have difficulty swallowing? Okay? Right? Yeah, they call it dysphagia, but what is the sign? Drooling. Okay? Picture the 2-year or a 18-month-old that's cutting teeth. They're always slobbering all over themselves because it hurts. Okay? Do they have dysphagia? Do they have the difficulty swallowing? No. Okay? They're just being a kid. All right? It's one of those snot-nosed kid kind of things. All right? So that's why you have to think about how do you tell? Does the patient need more neostigmine? Because do we automatically tell them, well, you need to take more of your neostigmine? Okay, so that's why we use that selective half-life of the edrophonium. It's short, and if we make them sicker, sorry. The good news is you're going to feel better in a little while, and that also tells me we need to change your dose of neostigmine. Okay, is that long answer? Does that help get a picture in your mind? Yeah. Okay. All right. And guys, I understand that this, today's lecture, I saw eyes go 21 neurotransmitters. Oh, you got to be kidding me. All right. But if you guys don't understand epinephrine, norepinephrine, acetylcholine, and a little bit of dopamine for exam 1, yeah, because hang on to your seats, because once we start talking about, later on in this course, we're going to hit on all 21 at one time or another. Okay?
Is there like a certain breakdown for full energy?
Yes, there are. And right now, just know that there are differences in clinical findings.
Yeah.
There are muscarinic effects, but don't worry about learning about them if you haven't started already. Some of your classmates cornered me and said, okay, and I was, no, not for the first exam. Just know that there are muscarinic effects and know that there are nicotinic effects. Okay? And for myasthenia, those are mainly, we're relying on that selectivity. Because acetylcholine, is it selective for muscarinic or nicotinic? No, absolutely not. It affects both at the same time. So that's why it gets a little confusing, because we tried to well, it only has alpha 1 effects. No, not really. It might have beta 1. So this, don't get sucked into that looking through a microscope kind of thing. Okay? Yes, there are, and yes, eventually I will make you learn how to differentially diagnose are these nicotinic effects or muscarinic effects. And I'll give you a really cool set of mnemonics to help you remember that. All right? I haven't given those to you yet because I want you to focus on the global idea of acetylcholine. Yes, it has nicotinic. Yes, it has muscarinic. Yes, ma'am. Explain number 9. Well, it's the number between 8 and 10. This is line 3. Differentiate between the nerve conduction with different types of axons. Okay? So basically, I just wanted to think, we have different axons in the body. Okay? What's the axon? Going back to like microanatomy. What is the axon? Okay? Yeah. axon is that long arm that goes out and connects to something. Okay? How long is it? Is that going to affect nerve conduction, velocity? Sure. Is it myelinated versus non-myelinated? Okay? Which is going to be faster? Myelinated. Okay? Thank goodness. So if we have a demyelinating disease, that's why it's so devastating. Can they move with the demyelinating disease? Sure. But the initiation of that movement, okay, Mr. Winter, we want you to put your right foot forward. It's slow. Okay? It's slow if you have a demyelinating disease. Okay? So, sure. And we have unmyelinated neurons, okay, that may also be part of this disease disorder, unmyelinated ones. Okay? But what is their role? How significant is that role? Well, if it's a demyelinating disorder, probably not. But that may be the body's compensatory mechanism so that you can continue to move. Okay? I'm going to start on this side. The sign-in sheet keeps Jenny off my back. Please keep Jenny off my back. All right? If you just initial. All right. Does that help? All right. I saw a hand up over here, Mr. Sunday, I believe. You had a question, sir?
Yes.
Okay.
I was just trying to double check from question number 10.
Question 10.
Yes.
Yeah, that's a really complex question, isn't it?
Yes.
I should have broken that into several.
Yeah, you said yesterday we should ignore Huntington's disease, but this part in number 10 is pretty much under the pathology. So compared to the pharmacology part, when treating about the drugs,
Right.
today, like, do we still focus on that? When
Okay. Number one is that you have to understand the pathology of these diseases.
Right.
Okay? So, do we know the etiology for some of these? Absolutely not. All we can say is it's an autoimmune disorder. Okay? It's a genetic disorder. Okay? So you can inherit it. All right? So, and for the treatment, when I talked about the treatment today, it's like, okay, if you understand the pathology, okay, if you understand that myasthenia gravis is an autoimmune disease, you're producing antibodies for the acetylcholine receptors at the motor end plate, the pharmacology makes sense, okay? If you have multiple sclerosis, an autoimmune disorder, immunomodulators, immunosuppressants are going to be our approach to prevent the progression of the disease. Okay? Huntington's disease, since it's genetic, Huntington's disease, it's like, yeah, we're still trying to get a handle on that one. And in class today, did I give you really good drugs to treat Huntington's disease? Well, I gave you some drugs, but we're actually using the side effect from drugs to treat the movement disorder. So how good is that? It isn't. Okay? So, the clinical findings and the possible drug treatments, I tried to roll that into one question, and then later on I asked you the same question. Okay? Since this is pathopharmacology, we have to understand the pathology of our diseases. And then I'm going to try and talk about drugs and the rationale for why we use those drugs for the treatment of the disease.
What about
Guillain-Barré? Guillain-Barré is one of those where we don't know what starts it. And most patients, if we have good care, they spontaneously recover. So we don't know what starts the recovery.
So like if you were to ask us a question then about
I won't
this-
ask, you know, just know that it's an autoimmune disorder. Just know that it is an ascending paralysis. Okay? There are, later on, we'll talk about disorders that can cause a descending paralysis. Okay? There's a great poison that causes profound descending paralysis. Botulism. Okay? Guillain-Barré, man, we don't know what starts it. And all of a sudden these patients start waking up and they walk out of the hospital. It might be 6 to 9 months of hospitalization on a ventilator. And that's fraught with all kinds of problems, right? I put a tube in to breathe for you. I'm introducing a source for infection. And if you're not able to turn in your sleep because you're paralyzed, that's a source for skin breakdown. And we really need our skin. Okay? Did that help with that? I mean, that's a complex question, but it's one of those, think about the disease, think about the clinical findings. What's going wrong with that patient? And then that's going to make the pharmacology that we're using so far today in the early 21st century have it make a little more sense. Okay? What else?
Number 12.
Okay. All right, number 3, plan of care. What is a plan of care? Okay, well, that's something if you've ever played sports, that's before the game starts, this is going to be our plan of attack. We know they're weak on offense, or we know they're weak on defense. Okay, so this is a plan of care of the patient. So what's today's plan? And you have a problem list, and you number that problem list. And that problem list is going to change depending on clinical findings, lab results, and everything along those lines. Okay? So, what can be part of your plan of care? Pharmacology can become part of your plan of care, right? And the patient's unique characteristics. How do they respond to that drug? What kind of side effects are they having? Are they having side effects? Is it making their symptoms better or worse? You always hope, I'm going to give you this chemical, you always hope it's going to make you better. But we have to go back and assess, are we actually doing that? And if it's not, then we have to figure out. So, nursing interventions based on drug administration. How easy is it for you to give that drug? Okay? There are certain medications, you know, you think of IVs. We should bring an IV back. The plastic IVs, there are certain medications that will actually react with plastic. You put the drug into a plastic IV, it binds the plastic. You run the IV, the patient gets the fluid, the drug's stuck to the inside of the bag. How effective is that going to be? So certain drugs have to be in glass bottles. Certain drugs require specialized tubing because what kind of tubing are you hooking that patient up to? Okay? So being familiar with those drugs, and we'll talk about a few in this course. But, you know, are they going to be a problem to administer? There are some drugs, fluorescent lights cause the drug to break down. And when the drug breaks down, it forms cyanide. Okay? So those are our drug administrations. Interventions to enhance therapeutic effects. What are some things that are going to make the drug work better? What do you guys think at this point? What are some things to do to make the drug work better? Educate the patient. Okay? You tell them, hey, this is going to make you feel great. The patient's going to, okay, I'm going to go look for that definition of great. Okay? Because the human mind is a powerful tool. All right? If you go in and you say, well, here's your medication, and we hope it works. Seriously? And how much is that medication that you hope works? All right? So your demeanor can affect efficacy. Okay? So to enhance their, oh yeah, this is the best stuff. And if you've ever been around an oncology nurse, those cancer chemotherapy nurses, some of them are just cheerleaders. We can cure everything. Okay. But they believe it, and they'll come bouncing in the room. Sis boom bob, we're gonna cure your cancer. Well, as pharmacologists, you're gonna be into remission. Okay? And you have to wait for years before we can say we've cured you. Right? So, but for a lot of patients, just their attitude helps the patient. Does it make the drug work better? In some studies, yes it does. Patient attitude. Okay? Interventions to minimize adverse effects and interactions. And I'm not talking personal interactions talking to you. I'm talking about drug interactions. How do we minimize those? How do we minimize drug interactions? I'm sorry? All right, drug names. So it's one of those where that's part of the history tape. You take any other medications on a day-to-day basis. You take any over-the-counter medications. You take any herbal preparations. Okay? Then you ask the same question over and over and over again to make sure that there are no other drugs in that system. Because if there are, you're running the risk that you might have a drug-to-drug interaction, or a drug-to-food, or a drug-to-herb interaction. Okay? So being familiar with what the patient routinely takes is going to help minimize those effects. And if you know that they routinely take it, it's like, okay, I better watch for these signs and symptoms of a possible interaction so that you're more vigilant. Minimize adverse effects. How can we minimize adverse effects? Or are they just going to have to live with them? You can tell the patient what to expect. All right? And it's one of those to minimize the adverse effects. Okay, for some people, okay, if I know that this is going to make me nauseated. Okay, how are you feeling? Oh, I'm doing good. Okay. Are they less nauseated? Maybe. Okay, but preparing them mentally for these adverse effects. Also, we might be able to mitigate those, or got that college word again, mitigate. We can lessen the adverse effects, the risk for adverse effects. How? Change the formulation. Okay? Something that's enteric coated. Okay? something that has a more pleasant taste. All right? Change the route of administration. Change the frequency of administration. That will help reduce adverse effects. If you have to give 6 pills around the clock, you're taking a medication every 4 hours around the clock, how grumpy is that patient going to be by day 2? Every 4 hours around the clock, here you go. Wake up and take this pill. It's to help you sleep. What? You're waking me up to take a sleeping pill. Okay? That can also affect the adverse effects. Patient education. I can get that very straight. Patient education. The more the patient knows, and you may have to use language, and you may have to ask, so what do you think your risks are? After you go through the education, make sure that they understand you. Okay? I think I use, and you're going to have to be very fluent with your explanation so that you can guarantee the patient understands you. You're going to have to talk to them at their level. And so that's going to take time to develop. Because you're going to walk in, yes, we need to monitor you for borborygmia. Most patients are going to be like, for what? They're not even going to know that that is gurgling sounds in the belly. That is the medical term for gurgling belly, borborygmia. If you use that, 99% of your patients are going to go, ooh. All right? I don't know who I told the story to, but I'll use this one. I took a phone call. I said, okay, Dad, this is going to cost lots and lots of diarrhea. What's that? Your son's going to have lots of stool. What's that? Okay. Your kid's going to shit a lot today. Well, why didn't you say that in the first place? We were now communicating. I thought, okay, diarrhea. There's enough commercials on television about diarrhea. No, we weren't communicating. So it's one of those where you have to make sure, as part of your patient education, you're communicating. All right? And his, well, why didn't you say that in the first place? Well, sir, it is supposed to be, a medical hotline, so I'm supposed to use the big words. Okay? He goes, well, you and I weren't communicating. I said, I understand that. Ma'am, what other questions do you have? And I will talk to you on your level. Now that I know where we are, I can do that. Okay? And you'll get caught up in it. You're talking, okay, you're talking to a kid, you have a tummy ache. And the little kid's going to be able to understand that. And then you're going to turn to the clinician and say, yeah, he's got a tummy ache. He's got a what? Okay, well, all right. He's having abdominal discomfort. So we're going to have to change the level as part of the communication process when we're caring for patients. Objective criteria for evaluation. All right, I'm going to give you my standard story. What are the differences between signs and symptoms? You see signs, okay? The patient complains of symptoms. Some of those things you may be able to, what kind of problems do you have? Well, I'm bleeding. Okay, that's a pretty good sign. I can see that. it hurts. I can't see hurt, but I might be able to look at their face and go, okay, they've got that hurts kind of look, all right? So if the patient is telling you about it, I've got a headache. I've got a headache. All right? So you can't see a headache. Sometimes you can see muscle spasms. You know, I'm having spasms. Sometimes you can see the spasms. But at first, that is just the patient's complaint. Okay? So objective criteria for evaluation: can you see it, touch it, feel it, hear it, get a blood level back on it? Those are your objective criteria. Okay? Subjective is, I feel a little better. Define a little. Okay? Or I'm feeling sick today. Okay? What's your definition of sick? All right? Patient's definition of sick and your definition of sick are going to be two different things. All right? So, subjective, objective. Can you measure it? Okay? Does that make sense? Does that help put it together? Pretty lengthy, but you know, sometimes the lengthy explanation makes it finally drives the point. Okay? Yeah, that was number 3.
For the bottom, just the bottom.
98.6, 37 degrees, yeah. Well, and yes, they're all ranges, okay? And I want to get you to start learning the vital sign ranges, okay? Because eventually, we're going to start doing lab values, and we're going to start doing other things as part of this learning process. So, heart rate, blood pressure, temperature, okay? Respiratory rate. And, you know, it's one of those where it's just like, do I remember all of my lab values? Absolutely not. But I remember like the middle number of that lab value. The normal glucose is of 100. Now I know it's a range. Okay? But it's one of those where, okay, lab values, normal sodium, normal potassium, those things. I remember the middle of the range, and it's like, yeah, and I know it's on either side of that. Okay? And I'm hoping the exam question is going to be way on either side of that middle number that I try to remember. Okay? Yes, ma'am.
So then can you help put into perspective number 12 as like a question?
Okay. Number 12, the effects of neurotransmitters with respect to vital signs, the effects on metabolism, sites of action. So it's going to be a question that's going to be it's a catecholamine. Okay? I may not, and so as soon as I say catecholamine, what does that mean at this point? That's just a big $5 word, I know. But what neurotransmitters are catecholamines? Automatically, you should think about it.
Your
I'm sorry?
parasympathetic.
Catecholamines are going to be sympathetic. Okay? So can you see an exam question coming out of that?
Yeah.
All right? So if I say catecholamine effects, you'd better start thinking about dopamine, norepinephrine, epinephrine, all right? Those are all catecholamines. And that's sympathetic. Sympathetic stimulates. So I'd better look for something that looks like a stimulation of a body function. Okay? Parasympathetic usually inhibits. Okay? So, and parasympathetic, if I say, so those would be cholinergic. I'm sorry, yeah. That would be acetylcholine as your neurotransmitter for parasympathetic. Okay? So that gives you an idea of what kind of question, because if I say catecholamine, it's like, oh, okay. Or I could write the question to be as specific. What are some of the, which of the following would be stimulation by epinephrine? Oh, wait a minute. I put that into that catecholamine category, so that's sympathetic. So let's see which one of those. Okay? Does that make sense? Oh, yes, ma'am. 27. Okay. Sure. 27. Rationale for using cholinesterase inhibitors to confirm the diagnosis. So, we don't have a blood test that I can draw, send to the lab, and they're going to go, well, you're presumptive for myasthenia. Okay. For myasthenia. No, yeah, that should be for myasthenia. Because I made a mistake when I wrote it the first time. There's a new addition up there. Aha, snuck it in. All right, and I actually wanted that to be a myasthenic process. All right, sorry guys. No wonder I keep getting asked that question over and over and over again. I made a mistake. I was getting tired. My brain was going, okay. So now for a myasthenic crisis, does that make sense where I'm going to be using a cholinesterase inhibitor that helps with my diagnosis? And it's not going to help with multiple sclerosis. Okay. All right. And one of your classmates quickly sent me an email saying, huh? And I went, oops. Sorry. So I rewrote it and I reposted it. Okay? And I'm sorry I created that confusion. Yes, ma'am. 22. All right. What if you were if what did I say this morning? Okay, I said you'd better know dopamine, norepinephrine, epinephrine, and acetylcholine. Okay. Oh, by the way, we have more neurotransmitters to talk about. Okay. So if it's the by the way, that's sort of like the smaller print in your textbook. Okay. So at this point, I just wanted to introduce you to the other members of neurotransmitters. And then as the course progresses, I'm going to expect you to know more and more about those neurotransmitters. Okay? So if you do not know the effects of dopamine, norepinephrine, epinephrine, or acetylcholine, you're not going to do well. So that, all those 21? Yeah, okay, let's just narrow it down to 4. All right, we're close to the exam. We're going to narrow it down to 4. Why did I bring it up today? So that I could talk about it after the exam. All right? Selectivity. Yeah, and selectivity is a relative term. Epinephrine is completely non-selective. Okay? Epinephrine, okay, it's a little more selective. Overall clinical effects, man, there's not a hill of beans difference between those two. Okay? Now, it's interesting. In the care of a patient, they'll wait and use epinephrine last. Okay? The trade name for epinephrine is Levofed. It has the nickname, since it's the last ditch kind of drug for critical care, leave them dead. And as a pharmacologist, there are certain times where it's like norepinephrine would be the drug of choice to treat what's going on with that patient. But to get them to use it first, oh no. Because that's only reserved for patients that are dying. But if we don't give them the norepinephrine now, they're going to be in that category in a couple of hours. So I'm trying to prevent that going to be dying kind of stuff. But you know, the practicality is, yeah, they're very, very scared. Because here's the thing. I want you to think about this, and this is under that administration. So if I say, okay, I want you to put an amp of 250, and I want you to start an IV. And if the only IV is the little veins in the back of your hand, and I start that infusion of any of these vasopressors, all right, norepinephrine, epinephrine, or dopamine, as soon as the first molecule hits, you get vasospasm. Okay? So now you have no blood flow coming out of that hand. So what do you think happens to that vein? It goes boom. And now we've got norepinephrine, dopamine, glutamate under the skin, and extravasation. What did I talk about as a risk? Necrosis. Loss of that limb. Okay? So you have to use a bigger vein. So you use the antecubital vein. That's a little bit bigger, and sometimes they'll give it into the subclavian vein. All right? But you try to give it into the largest vein possible, because if the vein is this big around versus teeny tiny little vein, so you get constriction. Okay, it can only constrict so much. A big vein can only constrict so much. Little veins, no, they'll occlude. They'll block themselves off. So how effective is that? Yeah. Okay. So these, you know, what's the difference between epinephrine and norepinephrine? Well, okay. Yes, there is a difference, selectivity, and you also need to remember, selectivity is a relative term. I can give a very high dose of dopamine, and it'll have effects at alpha 1, beta 1, beta 2. At low doses, it's only dopamine. So the dose makes the selectivity. So that's why I'm saying this is a relative term. Okay? Does that help?
Yes.
Sometimes it's hard to see if it's the same thing. All right, what else, guys? We got another hour. We got room for another hour. You guys know it? I don't know what I don't know. Yeah, that was the first question the dean asked me last night when she got in the truck to ride home with me. She said, so, do they know it? I said, well, I'd say some of them, yes. Some of them aren't sure what they don't know. She goes, okay. So it sounds like they're right where they normally are for first exam in this class. I said, yeah, unfortunately. Unfortunately. Okay? Who feels like you're drowning? Yeah. Trying to take that drink from the fire hydrant with the Dixie cup. That's all normal. Okay? Exam preparation, review. Don't try and cram it all in. Get a good night's sleep before the exam. Eat a good breakfast before the exam. Okay? As best you can. I know it's going to be tough. Yes, ma'am.
Number 24, please.
I'm sorry?
Number 24.
24. Okay? Describe how, in many cases, control of key activity in the CNS involves more than one neural pathway. So that's what I introduced today. Okay? So, and again, you know, is it more muscarinic effects, or is it nicotinic effects, or is it sympathetic, or is it parasympathetic? You have to remember, there are thousands upon thousands upon thousands of receptors, and it all depends on what molecule is closest to that receptor as a possible clinical effect. So do not look at this like you're looking through a microscope. Keep in the back of your mind that there are other things out there that could be effective. Alpha 1, alpha 2, beta 1, beta 2. Okay? So the human body needs all this to maintain homeostasis. Okay? And you have to remember that we have feedback loops, okay, that are saying, oh, we need to raise this, and it'll get to a certain point, and then that feedback loop will come in and go, okay, we need to slow this down so that we can maintain homeostasis, maintain blood flow, maintain urine output, maintain consciousness, okay? And so the neurotransmitters that I talked about today, we're going to be adding to that as this course progresses so that we can build on that, and this is going to become more and more and more apparent as we go through the course. That, oh yeah, so if I give this, although I expect this negative effect, there's still going to be a stimulatory effect because these receptors are nearby. Okay? Is that? So don't look at this as only a single pathway. Start thinking beyond that. Because of the you know, for example, you got that neuron and you got your alpha 2 receptors. Those are presynaptic. Okay? Postsynaptic, alpha 1, beta 2. Okay? If you have neurotransmitter being released, and if the wind changes, and you have alpha 2 being affected, that's going to decrease neurotransmitter release, so that's going to decrease alpha 1, alpha 2. So these things are all working in concert. It's kind of cool. Okay? So it's one of those, and it could be simple things. What's going to make insulin work better? Well, it's going to depend on your serum potassium. Really?